Welcome, everyone. We're going to start in approximately 3 minutes. I'll just give everybody 2 or 3 minutes so we don't miss anyone at the very start. We are going to record the whole presentation and make it available later for anybody who didn't make the original launch. So I'm going to stay quiet for a couple of minutes, but at exactly 12:03, we will kick off. Right, welcome everybody, and good afternoon. Welcome to the launch or relaunch of the Cardiovascular Atlas of Variation. We're going to record the whole meeting and make it available online for anyone who was unable to attend the live version. I'm going to do some introductions. Firstly, I'm John Goodfellow. I'm the clinical lead for the Cardiovascular Network. And alongside me are my co-authors, co-workers. We have Dr. Michael Thomas, who's public health consultant in Hywel, and then Lloyd Evans, who's head of health intelligence, Jamie Sullivan and Andrew Dring are both advanced health intelligence analysts, and they've been working to develop the Atlas and bring it to you in its current form. A little bit of background. The original Atlas, the Cardiovascular Atlas Variation, was published in 2019. It was the first of its kind in Wales. It used data then that was from 2016 to 2018. And we produced a printed version, a book. As such, it was static. It was useful, and we did make an e-version available. But the ambition had always been to have a live version of an atlas that was kept up to date. And I'm very, very pleased really to be in a position to say to you now we have an atlas that's been refreshed. It's been developed into a Power BI dashboard format. It's interactive and the data is as live as we can get it. The latest data, I think, is 2024, which is really good. As before, though, we have followed the same format and the same pattern that we had in the original Atlas. And that was to try and mirror a patient's journey from their community through the healthcare service. So they've gone through primary, secondary, tertiary care. And the Atlas focuses on risk factors and behaviors, but it also looks at 3 major cardiac conditions, atrial fibrillation, acute coronary syndromes, and heart failure. But I think very importantly and new to this iteration is a new chapter on cardiovascular disease mortality, and specifically a category of avoidable mortality. So this is going to be the first phase. It's not the finished article by a long way. We have plans to add more analysis, specifically linking risk factors, behaviors, and disease to deprivation levels, and we'll use the Welsh Index of Multiple Deprivation. And in the future, we also want to include costings for the hospital-based treatments, which was a feature of the original atlas. And keeping to a value-based healthcare approach, we would like to, in future, incorporate PROMs. So as we go through this presentation, I'm just going to wind up and hand you over. Jamie was going to take on the next part of this presentation. He's outlining the approaches we've taken and give you some more detail. And then when Jamie's finished, Andrew is going to run through a live demo of the chapters. And while Andrew's doing that, myself, Dr. Michael Thomas, and Lloyd probably will occasionally add comments, chip in. Can I please ask, though, for any questions you keep to the end of the presentation, so when Andrew's finished, you can put them in the chat bar, and Lloyd is going to be monitoring the questions. And we hope to have at least 15 minutes at the end to go through question and answers. So for now, thanks for your attention. I'm going to hand over to Jamie, who's going to run through a short presentation of the approaches we've taken. Thanks.
Thank you, John. So hello, everyone. Thank you for joining us today to launch a brand new NHS Wales Cardiovascular Atlas of Variation. So as John said, I'm Jamie Sullivan. I'm an advanced health intelligence analyst, and I'm part of the team that has put this together. I'm going to begin this section of the launch by providing a bit of context around the Atlas and how we've got to where we are. I'll quickly run through the order of events. I know John's touched upon these, but as I've said, I'll start by providing a bit of context, introducing the project and its purpose. I'll then hand over to my colleague Andrew Dring, who will lead on the live demonstration. John and Michael will be on hand to provide key messages and insights throughout. We will then finish with a Q&A session and discussion. As John has said, if I could ask you to save your questions until the end, that would be great. But if you do have any burning comments or questions, please pop them in the chat, and Lloyd's on hand to pick them up. So firstly, I would like to describe the purpose of today. So why are we here? We're here to launch the new NHS Wales Cardiovascular Atlas of Variation, show a refreshed, expanded and more accessible tool. We're going to showcase what's new, including updated data, new chapters, enhanced features, and reflect some of the user feedback we've got. We want to highlight the value of variation analysis, helping us understand and monitor variation and identify opportunities for improvement. I want to acknowledge that this has been a collaborative effort. So the Atlas is a result of cross-team expertise, dedication, and a shared vision. And then, most importantly, we'd like to invite your input. So your feedback will shape future development and ensure that the Atlas continues to meet the needs of its users. So as you can see on screen, we'd like a lot of people have been involved in the Atlas, so we'd like to extend a huge thanks to everyone that's helped us get to the dashboard ready for launch today. As you can see, there's been a lot of input, and apologies if I've missed anyone from that list. So outside of the core team, I would like to thank Sally Cox and Rebecca Capel for providing us with the heart failure data taken directly from the Value in Health heart failure dashboard. So it saved us a lot of duplication of effort, and we've also had an opportunity to manage to explore new ways of sharing data, which has been great. I'd also like to thank Andre Fideli in OCAT in Public Health Wales for his continued support throughout the process, particularly his help with the GP cluster analysis. So for those who aren't aware, I'll touch upon the original Atlas. So the original Atlas variation was published in 2019 and contained data up until 2017-2018, which is quite dated now. It was published as a static PDF document, so making amendments was difficult, and also refreshing was quite clunky. So It focused on 3 major cardiac conditions, along with the cardiovascular disease risk factors, so smoking, physical activity, alcohol consumption, etc. And the primary aims were to identify, investigate, and help reduce unwarranted variation. So for the first time, the Atlas is now available as an interactive Power BI tool. So again, all the usual stuff. It allows faster data refresh, easier access, etc., etc. Again, the aims are the same. We want to reduce unwarranted variation in key aspects of cardiac care, investigate these causes of variation, and we really want to build on the original work which was done in the 2019 Atlas. So this time round, we have the same 4 chapters of lifestyle, behaviours and risk factors, acute coronary syndrome, acute heart failure, and atrial fibrillation, along with mortality. So the data will be presented and include 30 indicators. This will be presented at primary care cluster level where possible. There may be instances where we've had to use health board due to small numbers, data availability, etc. We are now able to break down the data by persons, males and females. So this is a new feature of this Atlas. Another new feature is that we're able to display trend data. So we have historic data, so from 2017-18 all the way up to 23-24. So that's a new feature. And again, it's been published as an interactive report, so enables iterative development. Indicators can be refreshed with timely data. So once the latest PEDU and ONS data becomes available, we are able to refresh on a regular basis. The new indicators and chapters can be added based on stakeholder and user feedback. So this could mean that things are removed or added depending on what suits the needs. And also this tool can improve data quality. So as data becomes more visible and accessible, it'll be easier to check, validate, and benchmark. So when you're looking through this data, there might be anomalies within it that warrant investigation. However, this may highlight poor data quality and not poor data accuracy. So the next refresh and what's coming next. So as I've said, we'll align our next refresh with the latest available data releases. So that hopefully that'll be this autumn. So as soon as PEDU and ONS data is available, we will look to refresh the dashboards and make sure everything is up to date. Following this, then the dashboard will be refreshed on an annual basis. So a couple of new features John has already alluded to. So more granular deprivation analysis, and also the costing information heat maps, which were in the original Atlas but haven't been included in this one yet. This dashboard is essentially a live document, so it's going to continue to develop. So based on your feedback, we can, like I keep saying, add or remove features as needed. I'd also like to emphasize that this is the first phase of the dashboard. We've been really keen to get this out there so we're able to gather your input and feedback, ensuring it serves the right purpose. We've also been really keen to get this dashboard out now because for those who don't know, John will be retiring in 2 weeks. We wanted to make sure it was published while he was still in post and take this opportunity to say a huge thank you to John for all his support, guidance, and for always providing opportunities to share and grow our work. So thank you, John. This is the last slide from me before I'll hand over to Andrew. So to access the dashboard, it will be primarily hosted on our data and analytics SharePoint page, but the dashboard will also be available via a direct link, which will be shared in the chat during this webinar and sent out via email afterwards. So access is available to anyone with an NHS email address. However, there are discussions ongoing how to extend this further, i.e. Welsh Government colleagues, and maybe further afield as well. And then an important point is, please can I ask you to refrain from accessing the dashboard until the end of the webinar, just in case it slows things down. So we just want to make sure this runs as smooth as possible. So that's all from me. I'll now hand over to Andrew Dring, who will start the live demo.
That's great. Thanks, Jamie. I'll just share my screen. Hopefully that's up and running. Okay. So yeah, as Jamie said, we've moved from a static document, I think of roughly 100 pages, to now a live interactive dashboard that allows us to keep information relevant, by refreshing the data when it becomes available, or even adding different types of data as appropriate. So the focus then behind this has been trying to keep as much information as possible from the original document through commentary and context, whilst moving to a more visually interactive output. So with the screen in front of you, every chapter is represented by a tab at the bottom, and each one starts with a brief overview or introduction, followed by visual split into their respective indicators. So each of these indicators then provides context on what's being shown, a map showing the variation across Wales, and then a corresponding chart. So for the majority of the dashboard, this will focus on primary care clusters, with a few maps and charts at health board level, where sample sizes are too small to present at lower geographies. So I'll run through the layout, the functionality, and give a demo of how to use these visuals. And then, as John mentioned, himself and Michael will come in and speak a little bit more to the practical use of the data. And then I'll bring Jamie back in for the final chapter, which he's worked on closely. So as you open the Atlas, you'll be presented with this cover page, followed by a list of contents, which includes a link to our feedback form. And yeah, we'd encourage everyone to use this if they can, to help us with future developments. As Jamie says, this is the very first version of this. So yeah, it'd be great to have some early feedback. This is followed then by a brief introduction covering the aims and principal use of the data. And that is followed by technical information, which provides details of data sources, analytical methods, and caveats and notes where necessary. Okay, so let's dive into the first chapter. So this is our cardiovascular disease risk factors. And the first indicator that we're looking at is the prevalence of hypertension. And as mentioned, we have the document commentary, down the left, followed by the map of variation in the middle and our corresponding chart on the right. So when looking at the map, we can see the variation highlighted across Wales by the gradient of blue, where the lighter colours represent lower values and darker colours represent higher values. Information on specific areas can be seen by hovering over the individual clusters, where you'll be presented with the relevant data. So if I hover over, let's say, South Wrexham, it'll give me the age standardized rate for that cluster. I can also select this, and it will highlight where South Wrexham is in the corresponding chart, which is ordered from high to low values, and also includes confidence intervals where appropriate. Above the charts, you'll see drop-down menus, and in this case, we've got different types of measures and a breakdown by sex. So in this instance, I can change from age standardized rates to crude rates and basic counts, and then by sex as well. So for instance, if I wanted to find out, let's say, the number of males in Anglesey, the gradient will change, and I can hover back over my map to find out exactly what that is, providing me with a figure of 5,810. Just take that back to opening screen. And then, yeah, most of the indicators within the dashboard also provide a health board output. And so by scrolling down, we can see the latest data across health boards broken down by persons, males and females. And as I hover over each independent data item, then we get their values and confidence limits as well. Something Jamie mentioned, which was a new feature to the dashboard, is looking at change over time. So here I have a trend showing data from 2020 to 2024, and I can navigate this by selecting different health boards. So let's pick Swansea. Hopefully you'll see a change in the health board and Wales values here, represented in Wales and pink. Health board pink, Wales orange, and then I can run through my clusters. So yeah, hopefully, yeah, that'll load up, and as I go through, you should see that change as appropriate to what you've selected up here. And this is the makeup and model for the majority of our indicators in the Atlas. So you'll see as we scroll down to prevalence of diabetes, it follows very similar. Sorry. Apologies. Yeah, prevalence of diabetes, it follows the same template of context, map and chart with selections tools. And also,
And then I'll
yeah,
pick you up in the co-op car park. Sure.
sorry, someone needs to be muted. Yeah, and again, similarly, this is followed by health boards and trend analysis. Quickly, whilst I'm here, I'll just go through how to export individual outputs. So if I hover over, say, this map here, I'm greeted with a few options. Probably the best one to use would be these 3 dots top right. And by doing this, I can share a link to the visual. I can share it in the chat in Teams or open in PowerPoint. There's actually a couple of options in PowerPoint. If I just bring up another window. So here's one I pasted in earlier, and it actually displays the live data of what's within the dashboard, assuming you have a live internet connection. So all the data remains valid and up to date as of when you connect. Scrolling down, we've got lifestyle behaviors and a slightly different output focusing on different measures. So we've got adults drinking above guidelines, fruit or veg a day, physical activity, adults who smoke, and working adults of healthy weight. And yeah, as you select through these, you'll get the measures by health boards. Basically at this level due to small sample sizes from the National Survey for Wales. Okay, so that is the risk factors. I'll jump across to the AF chapter.
Just as you're doing that, just before you kick into the AF, the ambition, I think, for us is to be able to look at the risks and behaviours and overlay on that the deprivation scores, because I think we all recognise that the most deprived populations are the most at risk. They're more likely to have the adverse behaviours, they're more likely to smoke, for example. And certainly when you look at diseases, they're more likely to suffer from cardiovascular disease. And I think that's going to be really, really important. It's an area where we have to start putting resource and we have to focus on. So before anybody piles into the question, say, why aren't you doing it? It's in the plan to do it. Sorry, Andrew.
No problem. Thanks, John. So yeah, moving on to the AF chapter, again, similar format, so hopefully it's all familiar as you go through. We've got our overview and introduction, followed by our first indicator, which is again related to prevalence, with our context map, chart and selection tools. And this is largely the same throughout. So yeah, moving from indicator to indicator or even chapter to chapter, not only can I see variation across Wales independently, but it's also possible to identify patterns, particularly with some of the support of the commentary provided. So as an example, if I do drop back to chapter 1 and look at my hypertension data, I can see that one particularly dark area here would be the Gen North network. And of course, as part of our commentary, we've got a couple of lines in here on how that at least half of all heart attacks and strokes are associated with high blood pressure. So if I move back to my chapter 2 and AF, and I look at my stroke and TIA register, then I see a fairly similar pattern here. So it's not just the ability to kind of identify that variation, but also particular hotspots or trends or patterns within areas that are related to your health board or locality.
Can I jump in again to be annoying?
Sean, yeah.
I was just to say that, hopefully as you're watching this, you can see it's pretty interactive, but also we're launching ABCD Plus, the prevention program with Public Health Wales Diabetes Network. This data is going to be useful. This current map is people who have had a stroke or TIA, so they're secondary prevention targets. And as Andrew was saying, you can jump back and forth between all the risk factors and this. So I'm hopeful that everybody working in the prevention arena are going to find this data really helpful. And hopefully, where there are, as Jamie mentioned, where there may be anomalies, where data entry is poor, that'll improve with time. Because as we start to use this, you can choose your metrics if you like, but that's the aim. I think as it gets used, if you start using it, the metrics and the data entry will improve. And good quality data will enable and facilitate better healthcare. Thanks, Andrew.
Thanks, John. So yeah, moving further through the AF chapter, we can introduce more clinical-based data. So we've got hospital-based data rather. So we've got emergency stroke admissions, and then we have trend analysis for males, females on this, followed by anticoagulation information and procedural information for ablation procedures, again, due to sample sizes presented at health board level. John, I don't know if you want to come back in and give a recap on these two or any others.
Yeah, just a brief word about ablation. Ablation is available in Wales, in Cardiff and in Swansea. AF ablation, that is. It's also in North Wales, the patients go to Liverpool Heart and Chest. But you can see from the colours, just look at the colours, there's great variation in the delivery of that service. And Swansea Bay have a higher level than anyone else in Wales. So for the people who commission the service and the people who are providing that service, there are questions to answer as to how do you improve? How do you get better access? For example, on this map, how do you get better access for Cwmtaf and an Iron Bevan? And for that matter, for Cardiff. So I hope, again, it's data that can be used by commissioners and data that can be used by the health boards as providers. So yeah, thanks, Andrew.
Thanks, John. Okay, so as I've gone through the output and function quite heavily in the first two chapters, I'll just briefly touch on what's in ACS and the heart failure chapters. So this chapter is actually the largest on the dashboard with 6 different indicators. And as with previous chapters, we start with prevalence or registry data. In this instance, secondary prevention of CHD, followed by data on admissions, length of stay, and admissions who received a coronary angiogram. And I think, John, you wanted to come back in on this as well?
Yeah, for those of you, on this one particularly, for those of you who are involved in providing the service of angioplasty for patients with an acute coronary syndrome, the data here doesn't reflect the data that's in MyNab. In fact, the levels of compliance with the 72-hour standard are much lower on this map than the MyNab data. And that's because this data is PEDU data. It's not MyNab data, so it includes all comers. The MyNab data, in a way, is selective. So the centres providing the service, there are 4, that's Newport, or the Grange, I should say, Cardiff, Swansea and Glenclwyd, all report to MyNab. But of the remaining DGHs, with the exception of Wrexham, none of them submit enough numbers to be reported in MyNab. So this is actually collecting the real world, the people who don't get through to the national audit. And there is a plea in this text to say that we do have available a form for the acute coronary syndrome pathway, which was developed by cardiologists in Wales and by a very good group of BHCW colleagues. And it's ready to go live on the Welsh Clinical Portal. And if it was to go live, data collection would be automated and we would get much better quality data. That's a little advert from me, I suppose. So I'm hopeful, again, that this atlas will be used as a catalyst to change and, again, transform the way we do things. Thanks for that opportunity, Andrew. I'll be quiet again.
Thanks, John. And then scrolling further on, we get to the minor data that John's just spoken about, and there's a few variations there of what we can look at again at a health board level. And then this chapter is closed off by mortality for aged under 75 from CHD. Chapter 4 then is heart failure. So again, it follows a very similar pattern to ACS, starting with registry data, followed by heart failure admissions, and then length of stay, and finally finished off with readmissions, of which I know there is a bit of discrepancy in the data, particularly around HALDAR in terms of how things are coded, and how things are captured there. So a bit of a caveat within that. I think John might come in a bit late to speak on that.
This is classically, this was picked up when Sally Cox and Rebecca were doing the dashboard work for heart failure. But it seemed to be an anomaly that the patients in HALDAR had a very high readmission rate, but it's a coding issue, as it turns out. These are heart failure patients who are seen in MAUs and same-day emergency settings for follow-up, but were being coded as less than one-day admissions. So we put that in there as a note. Going forward, that problem should disappear as the coding is corrected. But the story with heart failure is interesting because over the last 3 or 4 years, with the introduction of 4-pillar treatment, readmission rates are falling because the treatments are very effective. And we haven't got time, but if you go back and look at specific health boards, Swansea Bay have got a very good system for optimizing patients with heart failure, and their readmission rates have nearly halved over the last 4 or 5 years, which on a value-based healthcare point of view is great because it's great value for the patients. They're not becoming unwell and needing readmission, but financially it's great value as well for not using hospital resources, which are really expensive. Thanks again. Over and out from me.
Thanks, John. And I think that just brings us to a close on this chapter. But yeah, just to say a big thanks to Sally and Rebecca from DHEW, who have provided us with the majority of the data for this chapter and can also be found on their own heart failure dashboard. So the final chapter then is a new chapter. And as I said, Jamie's done quite a bit of work with this. So I'm going to hand over to him to kind of finish us off, as it were, in terms of the chapters.
Thank you, Andrew. So there are 5 indicators on this chapter, which I'll run through. I won't focus on the visuals themselves, as they are a carbon copy of previous chapters. I'll just focus on what each indicator is showing and the key message. So the first indicator is mortality from cardiovascular disease under age 75. I should say that all mortality indicators are under age 75, as this defines premature mortality. So this indicator, like I say, covers all cardiovascular disease and is available, the counts, the rates, the EASR. But I should say we've had to report aggregated 3-year rolling figures here due to small numbers. So that's indicator 1. Again, we have the health board breakdowns below the cluster level analysis. And then secondly, we have mortality from coronary heart disease. So this focuses specifically on coronary heart disease. So the ICD-10 codes used there are available in the tech guide. Again, carbon copy from above, counts, crude rates, age standardized rates, available by cluster and health board. If you scroll down, please, Andrew, to the avoidable mortality. And then, we have a section then on avoidable mortality, again, all under age 75. So the term avoidable mortality refers to cardiovascular conditions or conditions in general that are considered preventable or treatable. So the full list of ICD-10 codes used to classify avoidable causes of death are published by the ONS, and this is available in our technical information section too. But again, this section is displayed as above. So you've got, again, a carbon copy, but this time it's just avoidable mortality. The supporting text on the left-hand side will explain it a bit better than myself as well. If you'd like to scroll down.
Yeah, can I just chip in?
Yeah.
Just roll it back up. The avoidable mortality definition is an OECD definition, so it's an international definition, and the data that we've used and Jamie and Andrew accessed is ONS data. But what it means is it can be compared internationally, and it's a crude measure of a healthcare system. But I think this avoidable mortality is going to be really, really important for those of you working in public health. Because let's face it, in health boards at the moment, all the pressure is unscheduled care. It's very difficult to get people to focus and to put investment into prevention when every day is a crisis. But this is avoidable. That's the point. So avoidable means improving prevention and improving treatment and looking at pathways. So again, I'm hopeful that this sort of data presentation is going to act, as I've said before, as a catalyst to get people discussing it, to start looking at deeper into the problems, and hopefully start to put more focus into prevention, because we really need to do that going forward. The health service can't survive the way it's operating at the moment. We need to be more proactive. Sorry for the political dogma there. Well, I'll shut up again.
Just scroll down a bit, please, Andrew. There's two other measures in this section which are just straight up proportions. So try to think of other angles to come in at and display the data. Obviously, these can be taken out, adjusted, anything like that. This one's a bit of a mouthful. You can see there it's the proportion of all-cause avoidable mortality attributable to cardiovascular disease. So in a nutshell, this indicator asks, of all avoidable deaths out of all conditions, how many were due to cardiovascular disease? So it offers insight into the scale of avoidable harm caused by circulatory conditions. And then the final one, again, is just a proportion. Scroll down a bit, please, Andrew. And this one is the proportion of cardiovascular mortality that was considered avoidable. So this one is asking, out of all cardiovascular deaths, how many of these were avoidable? And this assesses the extent to which deaths from cardiovascular disease could have been avoided. So like I say, the last two measures are presented as proportions only. The numerators and denominators used are available in our tech guide. That's it for me. Thank you.
Thanks, both. I just wanted to touch quickly then on the final tab, which is our appendices section. So yeah, we've got populations for all the health boards, local authorities, and primary care clusters for reference. And then we've got our deprivation map by clusters, again with a table showing the percentages. And then furthermore, just a few external resources, so useful links. Here's where we can find what's coming next over the next few months. And yeah, once we get this out there and get more feedback, that'll help populate this page. A little bit about who we are, and finally a glossary for yeah, a lot of the terms that have been used throughout the chapters. John, I know you already spoke on deprivation, but I don't know if you wanted to come back to the map at all.
You can put it up, I suppose, because it's a similar map, isn't it? And it's at cluster level. So without just doing the analysis, you can flick between the deprivation mapping and the disease prevalence, the risk factor prevalence. Previous iteration of the atlas, we did correlations with deprivation. So I'm hopeful in the future that will be available as well. So you can look at that very clear relationship between deprivation, risk, and deprivation and disease. So yeah, I think that's fine. Have we come to the end now, haven't we, Andrew?
In terms of the demonstration, that would be it, yeah.
Yeah. So it's really opening things up now for a discussion. If anybody has burning questions, feel free to put a hand up. Thanks, Julian. Julian Halcox.
Hi everyone.
Hi.
Yeah, really nice. It looks really interesting. I put a question in the chat actually. I was interested because we're doing quite a bit of work, as you know, others may not, but on looking at levels of blood pressure and lipid control across Wales in patients with established cardiovascular disease and risk factors. And we're looking at levels of blood pressure, levels of lipids, for example, and thinking about how we may be able to address those treatment gaps in people we already know to be at high risk. So it's really interesting to see your avoidable mortality data in there. And I was just wondering if you could expand a little on the methodology that you use to calculate that, and whether you're able to factor in testing, treatment control, and potential impact of better treatment of risk factors. You know, actually the things that we know, if they're delivered effectively, actually can go some way to reducing the burden of cardiovascular disease and antiplatelet therapy, AF anticoagulation, etc. Or is this just based on the level of deprivation and other non-specified variables?
Well, I'm going to pass that question to Lloyd and to Jamie and
I
Andrew.
can take the I can just run you through the methodology quickly for avoidable mortality. I'll share my screen, which is just the tech guide of the Atlas. So to basically calculate the rates and things like that of avoidable mortality, the numerator just avoidable death. So in this instance here, you can see under clinical codes, the numerator is just limited to these ICD-10 codes. So that would be our avoidable disease population, if you like. And then the denominator is just the normal population. Yeah, so I've got the full list of avoidable conditions below, but the cardiac ones are specifically here. So if a patient has one of those as their primary cause of death, it was considered an avoidable condition.
But it doesn't tell you how one might go about avoiding it based on what's currently being done for those patients. So it's, yeah.
Yeah, your question is in two parts, isn't it? So the first part is, if you like, dry. These are dead people, and reviewing everything, the OECD definition of avoidable death can be applied. It doesn't mean that all those deaths were definitely avoidable, though, because it can't. It just says, you know, broadly, they are potentially avoidable, potentially treatable, potentially preventable. I don't think we can answer your second part of the question, which would require an awful lot of data about individual patients, wouldn't it? So we can't. We can only answer the first bit. It sort of gives you a ballpark figure of the people who have died who were potentially treatable, avoidable. And it should promote what you're talking about, you know, focusing in on specific subgroups to say, what can we do better?
Yeah, exactly. So it's just giving an idea of what could potentially done if we were managing things better in general, rather than the specifics of what is still potentially changeable, given what we already know about those patients. For example, improving blood pressure, lipid, diabetes, smoking, antiplatelet, antithrombotic therapy.
Yeah, I think
it's a big picture thing rather than specific. Specific things that we can be doing.
But it gives you the scale, really. It gives you the target, the scale of what you're after.
Yeah.
Clive Weston, welcome.
Hello. Thanks, everyone, and congratulations, John and colleagues. I was just looking at the maps, and I put something in the chat, and Lloyd has answered this to a degree. Clearly, you're trying to draw the eye to demonstrate variation, and there are some dark blue and there are some light blue and so forth, and I was just trying to work out how you had decided to categorize. On the one hand, it's very attractive to have a large amount of contrast between different areas, And then down the right-hand column, you can see that actually in some of the metrics, the relative difference isn't that great between the highest and the lowest areas, and in others it is quite a lot in relative terms. So how did you go about deciding whether to fix the grade boundaries, if you like? How did you do that?
Happy to start on this, and then Andrew and Lloyd step in if I've muddled it up. But unfortunately, with Power BI, you can't set specific gradients or specific quintiles, sorry. So it's a gradient which adjusts based on the selection, so the sex or the rate count, etc. So it's something we are looking into tightening up, because it's something we are conscious of, but at the moment the software we use in Power BI won't let us distinguish our own quintiles.
Does that answer you, Craig?
Yes, no, it does. And I think the important thing was that you have on the same page, on the right-hand side of the map, you can look down and look at the actual rates, and it gives you some idea of the variation in sort of absolute terms.
Yeah. Thanks, Craig. Who have we got here? Which way around your name is? Renin?
Hi, hello. I'm Renin. I'm a cardiovascular epidemiologist, and my interest is more into spatial analysis. Thanks for the wonderful presentation today. I have a couple of technical as well as conceptual questions. So just to clarify, not to question. So I can see that the primary care clustering which you have used is for 10,000 population, but I was wondering what is the area level granularity you have used? Is it LSOA level or anything like that, so that the risk of ecological fallacy in the presentation of geographic variation maps could be minimized?
So yeah, I'll have a go at this one as well. So the rates have been standardized. It differs between different outputs. So sometimes the rates are being calculated per 10,000 population, other times per 10,000, per 100,000, per 10,000. It, like I say, it differs throughout. And then with the maps, so the cluster maps, we have populations which are registered to each GP cluster. So they've been used then for our denominators throughout.
Oh, okay. So the area boundaries which you're showing in the graph is the 10,000 cluster population, not any pre-existing administrative boundary, I assume.
Yeah, you're able to, so the denominator is just the population of that primary care cluster, and then it's up to you how you want to calculate the rate. You could do it per 10,000 population or per 100,000 population. It doesn't really matter.
Yeah. So one of the major issue with this would be the ecological fallacy or overrepresentation or underrepresentation of areas. So this could be combined. I can see a lot of scope for spatial analysis going forward to see significant clustering or high or low cluster identification in areas which is statistically significant and underpinned by denominator population in those areas, to see the contribution of area level factors in there. That would be great. And as you said, it's only primary care clusters. I assume you were only using read codes, not ICD-10 codes. That is mainly used in secondary care services, I believe. But in between, you have mentioned ICD-10 codes as well, so it was a bit confusing. It would be great if you can clarify how.
Yeah, so for the disease registry, so that is secondary care. There's all secondary care data. So the ICD-10 codes have been used, but then the population, it's just the population of people who live within the geographical cluster of a practice. So it's not the practice level data. It's just the people who live in that area. If that makes sense.
The residential area of the patients.
Yes.
Okay, I understand that. Okay, thank you.
Okay, thanks, Renan. Good questions. Diana.
Thank you very much for the presentation. I would like to know, I assume this information will be available. In which format will be available? There will be, the spatial information will be available, I mean, like shapefile that researcher we can download?
So the information behind the maps, so the data, the aggregated data, I think can be downloaded or exported behind a particular visual. So it can be accessed then.
Okay, I'm not sure if I allowed for a second question.
Yes, go on.
Yes, my second question will be, I don't know if maybe I missed it, which of those indicators that you took into account could reflect the influence of the environment on the number of cardiovascular diseases?
Sorry, just do you mind repeating it? And
Yes.
I'm gonna activate Michael Thomas while you're talking. Go on. Answer.
Okay. Any of those indicators that you consider, maybe not, show the influence of the environment. When I say environment, I mean the availability of green areas or places to make exercises. How that influence in the number of cardiovascular disease?
Okay.
Yes. Oh,
Michael?
okay, thank you. Yes, in relation to the indicators we have included, we've got some elements linked to that, essentially around, physical activity, overweight and obesity, poor diet and nutrition, for example. And of course, that information is captured from the National Survey for Wales. I know there are some limitations for that. It's only conducted now on a 2-yearly basis, only includes around 12,000 population, but that is the best available information we have to date. So those are the only risk factor elements we've actually captured, really.
Thank you very much.
Thank you.
Thank you. I can't see any more hands up. So I'd like just to point out that the link to the atlas, Jamie's put it in the chat bar. We're also going to email it out, I think, to all the attendees. And as we said at the beginning, it will be on the SharePoint site. So it should be accessible. What I would really like for everyone is to just have a look at it, play with it, use it, and please feedback, because this, I think, has got real potential. But the more that people use it, the more feedback we get, the better, hopefully, we can make the product, and the more useful that we can make it. So given that there's no more questions, I'm going to wind up. I'd like to really thank the teams behind this. And Jamie said at the start, it's a big team, but specifically I'd like to thank Jamie and Andrew and Lloyd. And also, as we've said, special mention to Sally Cox and Rebecca Capel, who did the heart failure data, and to our other colleagues in public health who've contributed to the data analysis. I'd like to thank Michael Thomas as well, who's worked on the original atlas and on this one. Please go away, play around with it, see if you can find it, if it's useful. Please feedback to us. I'm pretty certain you're going to look at it and think some of these indicators are of little value. We already sort of feel some of them are of little value, but they're in there because it's a refresh of the original. So we're not precious. We want it to be a useful tool. So some things that can be removed, we can remove them and replace them with others. Okay, so if there's no further questions, I'd like just to say thank you very much to everybody for attending and contributing. And I hope you all have a very good day. Thanks very much indeed. Bye now.
Thanks, all.
Thanks, John.
Thank you.
Thank you so much.
Thank you.